loud. All right. Hello, everyone. It's nice to see so many of you. Welcome to a Rafael Medina subspecialty case discussion. Today, the focus is dermatology, and we have two really phenomenal educators here who I am so excited to learn from. And my name is Maddie. I'll be facilitating today. So the case discussant who we have is Dr. Stephen Chen. And Stephen Chen, he's an assistant professor at Massachusetts General. And Stephen, he co-directs the Comprehensive Cutaneous Lymphoma Program at Massachusetts General Hospital and the Oncodermatology Program, and is also the director of the Inpatient Dermatology Service as well. So Stephen, thank you so much for being here. And before we dive into the case, I would love to just hear what you love most about dermatology and what drew you to the field.
Thank you for having me. I'm excited to be here. I think this is the second time I've done this, so it's great to be back. I'll try to give you the short answer, because otherwise I could talk for like 2 hours about this. So I thought that I was going to be an internist. I was ready to become a cardiologist. I was going to do interventional cardiology. And then I did a dermatology rotation my 4th year of medical school, kind of under the pressure exerted by my then fiance and in-laws, and my parents were like, you should give this a try. And much to my surprise, I ended up loving the rotation and even did a sub-I in dermatology and ended up loving it more. And I think what I really loved about it is it's so visual. You get to really see your disease get better and sometimes not get better. I love the fact that it is a window into everything else that's going on underneath the skin, which is really great. And like, let's be honest, dermatology is probably one of 2 subspecialties that most physicians are very scared of, the other one being ophthalmology. And it's kind of cool to be in command of a subspecialty bit of knowledge that lots of people need help with. And so at the end of the day, after seeing some really cool pathology and seeing really smart dermatologists take care of those patients and see them get better, it became really quickly pretty high up on my list.
I love that story, and I'm so happy you're here to help us all kind of get us away from our fears of dermatology. So thank you so much for being here.
Yeah, thank you.
And our case discussant today is Dr. Eamonn Maher. And Dr. Eamonn Maher, he is an assistant professor at the University of Minnesota. And he has a special interest in complex medical dermatology, particularly cutaneous lymphomas and connective tissue diseases such as lupus, dermatomyositis, and systemic sclerosis. Eamonn, thank you so much for presenting the case today, and would love, your perspective on what you love most about the field of dermatology.
Yeah, my story is actually surprisingly similar to Stephen's, where I thought I was going to do internal medicine, and then I did a rotation my 4th year. And I wrote about this in my personal statement, but the first patient I saw, a guy came in for like bullous bug bites, and the attending from outside of the room while kind of distractedly typing notes, after the resident listed the differentials, like, oh, like what about lymphoma? Because there are 3 diseases classically associated with bullous reactions after bites: CLL, NK T-cell lymphoma, and mantle cell lymphoma. And it's in a chart in the main dermatology text. And sure enough, we went back in the room and felt the patient's neck, and they had lymphadenopathy, and they were ultimately diagnosed with mantle cell lymphoma. So I was like, wow, like just like Stephen was saying, sometimes the skin really is like a window into serious disease, and you can get there in a much more like quicker and efficient way than you otherwise wouldn't be able to. And not every case is like that, but occasionally there are really cool cases like that.
Yeah, well, thank you again, Eamonn, for preparing a case for us to learn from. So I know we have quite a lot prepared, so I think we can jump right in. And Jimena, thank you so much for scribing. You can go ahead and share your screen. And Eamonn, whenever you're ready, you can start with the first aliquot.
Okay. So in typical CPS fashion, we'll start out with just the chief complaint. So the chief complaint is multiple eruptive nodules on the trunk and extremities.
All right. Well, exactly as you said, in typical CPS fashion, I think we can still get a lot of juice with just a few words. So, Stephen, I know this is just a few words, but I'm really curious, just with knowing that there are multiple eruptive nodules, what are key pieces of information that you would want to know? What questions would be really crucial for you?
Sure. So let me start by saying, so I, just like Eamon, really love internal medicine, really love dermatology. I was a terrible decision maker and ended up doing both. So I ended up doing both residencies. And the key point I would take away from that is that internists, I think, approach problems from an H&P perspective. They take a history and then look at the physical. Dermatologists do a P&H, right? So we look at the physical first, and then we ask questions to narrow in on our differential. So just to start off by saying how mean it is to not give me pictures right off the bat, but it's okay. I will forgive Eamon as a fellow dermatologist. So multiple eruptive nodules on the trunk and extremities. Start thinking a lot about what I want to know about is time course. I want to know about associated symptoms. Like, are there fevers? Because that would make me think more about infectious things. It could make me think a lot more about B symptoms. And so in terms of malignancy, so thinking about fevers, chills, night sweats, weight loss, all of that good stuff. And then in terms of thinking about infection, fevers, of course, puts you in the infectious differential, but at the same time, that's where your exam is going to make a big difference because the pattern may change what it looks like. Could it be papillonecrotic tuberculid like TB? Could it be something like in a sporotrichoid pattern because it's something like, I don't know, tularemia or mycobacteria? And so thinking a lot about already prepping myself for what the exam might look like is really important. Additionally, thinking about fevers and systemic symptoms, you start thinking about things like connective tissue disease, which can also present similarly with nodules, eruptive nodules. The other thing that I think about is, are these nodules pretty discrete? Are they pretty, do they kind of blend in easily to the background? That can kind of change how things might move up and down on your differential diagnosis. Do they ulcerate on their own? Because that also changes things. But really getting at tempo of disease, getting at distribution of disease, obviously clinical presentation of the actual skin findings, and then thinking also about like recent contacts, sick contacts, family history of stuff that could run in families. Those are all important things that I'd be thinking about right now.
Amazing.
If I
Yeah.
saw this chief complaint, I'd be really excited to see the patient right away. Like if this were like sitting in the chart as I was walking in, I'm like, this is going to be a good patient, you know?
Definitely. Well, without further ado, we'll pass the mic back to Eamon so that we can get some photos.
Yeah, Stephen, I totally feel you on the how we're used to receiving cases is a little bit different. And I felt the same way when I had my case. But don't worry, clarity is coming. So the first aliquot, as background, this is some details have been changed to protect the patient's privacy. This is a 60-year-old male who has a past medical history of clear cell renal cell carcinoma that happened to be incidentally picked up on imaging for a shortness of breath workup in 2016. At which time, so a unilateral kidney mass was noted. It was ultimately diagnosed. He had a right radical nephrectomy. And his disease was well controlled for about 3 years until a new mass was identified on his left solitary kidney. This was diagnosed as RCC again. He underwent cryoablation with radiological improvement. But ultimately it recurred again. And due to this being a solitary kidney, he was started on combination immunotherapy with axitinib, which is a VEGF inhibitor, as well as pembrolizumab. And he had radiological improvement from this regimen. Several months later, when he was in Florida, where he spends a large portion of his time, he started to develop, so we're reading this in, like outside notes, burning pain in his mouth. And within 1 to 2 weeks of this, he started to develop a rash on his shins comprised of pink to red papules. These were biopsied by a dermatologist in Florida and reportedly showed a dermal neutrophilic infiltrate without ulceration, perivascular neutrophilic inflammation without fibrinoid necrosis. And these are in the outside notes. Given the concomitant symptoms of burning mouth pain, which was diagnosed as stomatitis, and the neutrophilic rash, he was given the diagnosis of immunotherapy-induced Behçet's-like syndrome down in Florida before ultimately returning to Minnesota. And just real quickly, the past medical history, not really contributory, hyperlipidemia on a statin, no significant family history, and a CBC and a CMP were all within normal limits other than a creatinine of 1.61.
All right, thanks, Eamon, for giving us a lot of rich history here. And Stephen, I'm really curious what stands out to you in this information, and specifically how the history of renal cell carcinoma and immunotherapy influence how you're thinking about these eruptive nodules.
Sure. So I think there's a couple things, right? So thinking of the cancer itself, could the cancer itself be causing some type of skin eruption, be it just direct metastatic spread of renal cell carcinoma, which is possible? Those have on biopsy, a characteristically bloody appearance because clear cells tend to be very hemorrhagic when you actually do the biopsy and when you actually look at it under the microscope. Similarly, thinking about tumors, you can always think about perineoplastic processes that can also occur in the skin. So whether it's directly related to the cancer because it's either the cancer itself or perineoplastic. And then the third thing that really kind of jumps out is it a complication of his therapy? And so the fact that he's on a VEGF inhibitor is interesting, but the pembrolizumab is also something that really kind of piques my attention, piques my interest. So as a reminder, pembrolizumab is a PD-1 inhibitor. So this is an inhibitor of a co-stimulatory molecule, immune checkpoint molecule. So by blocking by using pembrolizumab to block PD-1, you're removing the brakes on the immune system so that you can fight cancer in a very antigen-specific way. The problem, as you might expect, is that if you do that, you also can fight self or fight your own tissue. And so we know that skin toxicity is the most common and the earliest to present after getting pembrolizumab. And so there are certain things that occur with pembrolizumab or with checkpoint inhibitors in the skin. When all these immune-related kind of issues are called IRAEs, or immune-related adverse events, and when they're in the skin, they're cutaneous or dermatologic IRAEs. And a couple things that I would think about, and Eamon, I'm not sure if you said this and I just missed it, like the time between the first dose of therapy, cancer therapy, to this onset of rash would be interesting to know. And then what's interesting about the kind of details here, a stomatitis from checkpoint inhibitor is almost always a lichenoid eruption, which is a particular pattern of inflammation under the biopsy. Unlike cytotoxic chemotherapy, that's different. And then he did have biopsies down in Florida, but what's interesting is that it was read as a neutrophilic dermatosis, which is pretty unusual in the setting of a checkpoint inhibitor. And so I would think a little bit about the fact that, is that a red herring? Could that be true and unrelated? Could it be something like a sweet syndrome that's actually perineoplastic as opposed to a checkpoint inhibitor associated eruption? Now, this is where, like, in full disclosure, 80% of the research I do is in checkpoint-associated skin toxicity. So Eamon is either being very nice to me or very mean and leading me down a path that is not that at all. So I'm excited to see how this turns out.
That was awesome. Okay, all right. So Aliquot 2 is going to be some extra history, and then the moment that we've been waiting for, some clinical photos. So he returns to Minnesota from Florida with these results, and given the lack of associated Behçet's-like symptoms, uveitis, general ulcers, arthritis, thrombosis, or otherwise significant internal organ involvement, he did not receive formal room evaluation, and his immunotherapy was continued. The leg rash resolved, and his stomatitis symptoms were controlled for the most part with a steroid-containing mouthwash. And he stayed on his regimen for several more months without any issue. However, he then developed these. So we sort of flash back in time, and now we're up to the time point of the chief complaint. He then developed these eruptive nodules on his extremities and trunk. There were roughly 10 in total. And it was at that time that the patient was referred to. He hasn't made it to me yet, but was referred to someone in our department. And the biopsy, the lesions pictured were biopsied. So let me share my screen. We'll stop. So this is going to stop your all sharing. And I'm going to go here. All right. So there, I'll let you take a look here for a couple seconds, and then there's some pictures of the upper extremity as well. Are you okay with me going to the next picture, and then once you have it all, then you can kind of...
Yeah, sounds good.
Yeah, and Stephen, whenever after you take a look at these, would love to hear how you would describe the appearance of these lesions.
Yeah, and are they, sorry, did you already mention this? Are they itchy or painful? Or do we not know that yet? Oh, sorry, I can't really hear you.
Can you hear me?
Yes, yes.
Okay, we don't know that yet.
Okay. So across the bilateral dorsal hands and the shins primarily, what we're seeing are these pink to purple nodules. Some might be superficially eroded on the most superficial aspect. They look scaly. They're ranging in size from, do you mind going back to the leg picture again? They range in size from maybe just under a centimeter to 2 centimeters in size. There was also one on the right sole of the foot that almost looks more like eruptive with this central crateriform ulceration. Do you want me to tell you what I'm thinking now? Would that be helpful, or is there more stuff to?
Yeah. So so the next aliquot is going to be the biopsy.
Okay.
So if you wanna throw out a DDX now, if you want to wait until we get the histology, either way is fine.
Yeah.
And,
yeah. Sorry. Go ahead.
oh no, I was actually just going to highlight a great question in the chat just about the term that you were using, eruptive, and just to clarify, is that referring to the associated loss of integrity of the epidermis, or can you talk a little bit about what makes you use the term eruptive for these lesions?
Is that question? I think that question's for Eamonn, right?
Oh, is that for me?
Or is that for
really? Yeah. Yeah, so that's actually a great question. And I don't know if there's an actual definition for it. I kind of, eruptive, I would generally, this is me personally, use it in the context of something that comes on rapidly, and is often like more exophytic than it is wide, I guess. Like it seems like a rapidly growing kind of like nodule or ball.
So I agree. I don't think the loss of epidermis changes whether or not I would use the word eruptive or not. So I mean, based on this, these are very discrete nodules that have kind of nodules, and given the size, some might even call them tumors, but really I think these are more nodular, more so than anything else. Given all the kind of history that we've heard so far, one thing that I would think about is this a lichenoid eruption? It is unusual because it's so few in number. Usually it's a little bit more kind of diffuse. There's more of them. And the biopsy would be very helpful because the biopsy would include a lichenoid infiltrate that would help us. And when we like, I keep saying the word lichenoid, but all it is just a description of the way the pathology looks, where you have a band-like infiltrate of lymphocytes at the superficial dermis. And if it is something lichenoid, that'd be a very typical reaction that you would see from pembrolizumab. The other thing that I would throw on here is, I don't think he's immunosuppressed because he's on like immunosuppressed in the classical way in terms of like prednisone and other immunosuppressants. Sure, all cancer patients in general probably have some immune dysregulation that we have to think about. And he's certainly immune dysregulated or immunomodulated from the pembrolizumab. But if I saw just these pictures, I would be thinking about infection as well. And this is someone where I would probably do a tissue culture if I didn't have that history, just to make sure that we weren't missing anything. But at the top of my list right now is this some type of IRE from the skin? Is this some type of disseminated infection? And it certainly doesn't sound as much like that because everything that was kind of acute seems to have gone away at this point. And I think the other thing to think about, because of the sole lesion, you could also think about perforating disorders, which are certain things that are associated with systemic disease like renal disease, diabetes, that type of thing. Not classic for this group of diseases from pembrolizumab, but that would be in the back of my mind as well as something I would be looking for. Maybe mention on the derm path requisition so that they know that that's something I'm thinking about too.
Awesome. Okay. All right. So these spots were obviously biopsied.
Okay. Can I throw something else on there? So the other thing is skin cancer, right? So like, could these be like eruptive squamous cell carcinomas that, like, if you didn't know anything and you saw these, you're like, oh my gosh, this person's got skin cancers all over the place. And we can talk a little bit more about that when we look at the derm path, because I think that's an interesting distinction that we always talk about in this group of diseases.
Okay. So these lesions were biopsied, and there is.
Oh, Eamon, just so that we can all hear you, your volume went down a little bit. I'm not sure if you moved.
Maybe I'm covering.
Perfect. Now it's perfect.
I think I'm covering the microphone. Okay.
Now it's perfect.
Stephen, so this is sort of a zoomed out photo, and then I believe we have a more zoomed in one. So and we have the the requisition here, which I can read.
Sure. So, I mean, right off the bat, so full disclosure, I'm not a dermatopathologist. All dermatologists are trained a little bit in dermatopathology. I'm pretty sure I may have failed that portion of my board exam. So I'm going to try to take a look to see what I think about this, but I'm going to rely on our read for sure. So right off the bat, what we're seeing is really good CPC, right? So on the clinical, you saw that there's these big exophytic nodular lesions, and we are correspondingly seeing that right now with our dermatopathology pictures, because what we're seeing is this big mound, this nodule that looks like it's been shaved across the bottom. And so what we're seeing now, like the like little bridges of pink in the center really look like that's like some pseudoepitheliomatous hyperplasia coming down from the keratinocytes. So that's like some really thickened keratinocytes. All those like little dark blue cells that are in between the like finger-like projections would be the inflammatory infiltrate. So it'd be interesting to see what that looks like. And then when you're looking at, sorry, thank you for pointing things out. And then if you're looking at these like islands of keratinocytes, then the next question is, how atypical do they look? Because if you're thinking skin cancer, you're looking for atypia in those keratinocytes, whereas you wouldn't see atypia if you're just dealing with something that's like expanded like this. Something I was taught in residency is whenever you see an expansion like this, you always want to look at the bottom to see if it could be infectious, because lots of infectious things could also look like this too. Keratin pearls, I think, are an interesting thought. I do think that we see some of that for sure. Usually when we think about keratin pearls, I feel like we see a lot more of them than here. I think pseudoepitheliomatous hyperplasia is kind of the thing that jumps out to me so far. Did I totally botch that, Eamon?
No, I think that people aren't going to believe you that you're not boarded in dermatopathology. So here's the read. So the specimen exhibits scale crust and parakeratosis with a cystic, deeply endophytic proliferation mildly atypical and pale staining squamous epithelium. So that's what Stephen was talking about with those islands of keratinocytes, and he appropriately sort of touched on you need to identify how atypical they are. There's also a patchy lymphocytic infiltrate with eosinophils. The possibility of pseudocarcinomatous hyperplasia in the setting of a lichenoid reaction to PD-1 inhibitor therapy was also considered. However, the deeply endophytic and infiltrative nature of this proliferation is best interpreted and treated as a true atypical squamous proliferation. Which for listeners is kind of like a hedgy term that dermatopathologists use when they're not ready to come out and explicitly call it squamous cell carcinoma, but it's atypical enough that they don't want to be left on the hook for telling the clinician to not take it out. All right.
So Stephen, I'm curious how, after seeing this, where your mind is at between, is this, squamous cancer? Is this a lichenoid reaction? Is this something else? How were you thinking through those different possibilities?
So it's super frustrating, right? Because I think as a dermatologist, you wish you could do a biopsy and get the answer right away. But very frequently, I think something that non-dermatologists often think is just like, oh, just do a biopsy, you'll get the answer. But something that I talk a lot with my dermatopathology colleagues about is that if it's non-specific on the skin, like on exam, it's going to be non-specific on pathology. And so just to remind everyone, like dermatologists are making diagnoses by visually inspecting something, and pathologists are doing the exact same thing, just with a microscope. And so at the end of the day, like there is, like, while pathology often is the gold standard because they can do stains and do testing, it can be frustrating when you get some hedgy reads that can happen for sure. So just thinking about this in general, it would be awfully strange for a patient to come in with eruptive squamous cell carcinomas after starting pembrolizumab, when we know that pembrolizumab is associated with these lichenoid eruptions that can mimic what looks like a squamous cell carcinoma, because you can have something called hypertrophic lichen planus, which often is misdiagnosed, mistreated as a cutaneous squamous cell carcinoma, because clinically and pathologically they can look very similar. The other thing I would highlight is that checkpoint inhibitors are actually used to treat metastatic squamous cell carcinomas. And so it's also unusual to have worsening of a keratinocytic carcinoma when you're on a treatment that sometimes is even potentially used for it. It's not pembrolizumab, it's something else called cemiplimab, but that's also a PD-1 inhibitor with the same mechanism. So I think that read is concerning, because when you get that read as a dermatologist, like, oh no, I kind of have to treat this almost like a squamous cell carcinoma. But in the back of my mind, I'm like, this is strange. Like, I still really want to consider that this might be all inflammatory as opposed to all SCCs.
Amazing discussion. One follow-up question I had on that is, because we're still considering that this potentially is induced from pembrolizumab, would you consider stopping that, or what additional information would you need in order to make that decision?
Yeah, great question. So my whole job, as like this term that we've come up with for ourselves as oncodermatologists, and my whole job as an oncodermatologist is to try to keep my patients on cancer therapy as long as they can. And really quick plug for the field of dermatology, we've done research to show that when derm consult is involved, patients stay on therapy longer with fewer treatment interruptions. Now, back to the case. So I think what I would say here is that if the patient's not too bothered by these spots symptomatically, and there's only a few of them, it's really a conversation between the patient, the oncologist, and the dermatologist. I personally would advocate for the patient to stay on pembrolizumab while we're treating these spots, and we can talk about what the treatment's going to look like. And it might be trialing different things, right? It might be trying some things to see how it works, and if it doesn't work, then going back to the drawing board, repeating a biopsy, thinking about them more like skin cancers. But I do think that if the patient's not too symptomatic and the oncologist is okay with it and the patient's okay with it, I would advocate for keeping the patient on treatment. If you actually look at all the IREs of the skin, you can grade them. You basically adapt the CTCAE, which is a common terminology of cutaneous adverse events, which is something that we usually use for lots of patients who get drug rashes, most patients who get drug rashes. If you adapt it, you can grade these into 5 grades. So grade 1 is less than 10%. Grade 2 is 10 to 30%. Grade 3 is greater than 30%. Grade 4 is so bad that it's affecting ADLs and the patient needs to be admitted to the hospital. Grade 5 is something we usually don't see. That just means the patient's died from that IRE or from that toxicity. So in this case, because technically of their BSA, they're grade 1, and the oncologic recommendation from guidelines, from the oncology guidelines, are actually to continue treatment anyway.
Amazing. Thank you. Eamon, back to you.
There we go. Okay. So, so this patient hasn't made it to my clinic yet. Due to concern about possible, the team did some literature research and found a report of PD-1 inhibitor induced KAs. And wanting to balance morbidity of intervention, given the number of these lesions, the patient was treated with topical 5-FU. Oncology made the decision to stop the PD-1 therapy, and I definitely appreciate Stephen's nuanced discussion on that, and I think that is I guess I should start with this, like a good way to think about it. And so his therapy was stopped with oncology, and then I ended up seeing him only a short time later, a few weeks later, and the morphology of his lesions had progressed to those seen here. And I'm going to share my screen again. All right. So as you can see, these are kind of in the same area as the nodules on his shin previously. And so I welcome you to, these were ultimately biopsied as well. If you want to comment on these, please feel free. And if you would like to see the histology to accompany these lesions, I can skip ahead.
And maybe, oh yeah.
No, go for it. Go for it.
Oh, I was just, again, I think we would all benefit from hearing yourself kind of, how would you describe these lesions?
So yeah, so on the shins, we're seeing these large ulcerated plaques measuring in size anywhere from, what would you say, like 7 to 15 centimeters in size with overlying scale crust. Nothing that looks purulent drainage wise, which is, but rather it seems like it's more like an ulcerated, really just ulcerative plaques at this point, as opposed to anything that looks like, so sorry, when I talk about purulence, it's because I'm in the back of my mind, I'm thinking like, could this be that sweets thing again, which is usually going to look kind of purple and purulent, but that's not what it looks like. And so then the question becomes, well, is this an extension of the keratoacanthomas, skin cancer? Is this an extension of the lichenoid eruption possibly? Is this a side effect of therapy from the 5-FU topically? Is this some underlying infection that we never diagnosed and the patient does need a tissue culture at some point? Those are the unusual too, to be bilateral like this, but those are the things I'd be thinking about right now. So I'd love to see DermPath.
Okay. Asking you shall receive. So these lesions were biopsied, and they have the appearance here. And I think I have a more zoomed in photo as well. But Stephen, I don't know, maybe you could just comment on some of the differences between what we see in this picture as opposed to the last biopsy.
I will try, I promise.
Okay.
Please forgive me if I mess up. So I think right off the bat, we're not seeing as much of that like pseudoepitheliomatous hyperplasia. It's also possible we're just kind of zoomed out a lot more, so it's just not as like striking in the field. But what's really striking here is those like dark blue cells, right? That's occurring just under the epidermis. And so this is starting to make me think of that band-like infiltrate of a lichenoid eruption. And then the other thing you can see is just at the very bottom of the epidermis, you might see that there's a little bit of like space in between the keratinocytes, and some of those keratinocytes might be a little bit darker in color. And so, oh, great, perfect. So as you see, it's kind of like the inflammation is almost not attacking, but starting to get to the bottom layer of the epidermis. So it starts to make me think about something called an interface dermatitis, and then some dyskeratotic keratinocytes as well, which just means that they've kind of been attacked in some way. So they're kind of like balling up a little bit and looking deep purple. One thing that's just kind of fun to look at, if you look at some of those keratinocytes on the right-hand side, do you see all those like little purple striations? I always think that that's super fun to look at. So because those are the desmosomes that are holding keratinocytes together. And so when you actually see those, like that's the stuff that like you learn about in medical school, and you actually get to see it on DermPath. So that's pretty cool.
Yes.
I never thought I would see a desmosome. Wow. I had a quick question about, so you've talked about how on Path you can recognize a lichenoid reaction from kind of that band of lymphocytes. I was curious if you could comment on kind of clinically, what is the typical appearance clinically of a lichenoid reaction?
Great. So great question. I should have talked about that earlier. So a lichenoid reaction, so a lichenoid drug reaction basically looks like lichen planus. And lichen planus, like the two of them, both of them, the classic teaching is the P's. So pink or purple, polygonal, planar, peritic papules. So pink or purple, polygonal or planar just means like flat topped, and then they're peritic, so they're itchy, and papules, so less than a centimeter in size and raised. And they're usually, the most common location are the volar wrists, and then it can really be anywhere else. And you could see that with, sometimes it comes with like oral stuff. We mentioned in cancer, we think about lichenoid eruptions in the oral mucosa, but you can also have lichen planus of the mouth that gives you erosions. You can actually have LPP of the hair. You can have pigmentary disorders. That's all kind of in that family.
Thank you. And how would you kind of summarize where we are at with the case right now?
Before we do that, can I ask, Eamon, did I get the DermPath remotely correct here?
Yes, I think you are right on the money. They were, there's a lichenoid. Do you want me to just, you're correct. I can read the report. Or why don't you answer Madalena's question, and then that's sort of the next aliquot is the read, but you're on the money.
So if the path comes back more confirmatory for a lichenoid eruption as opposed to like something that looks like atypical squamous cell carcinoma, I think that kind of confirms what our original thought process was, right? Like, so our original nodules that we saw, we said, sure, the pathology suggested that it looked atypical for squamous cell carcinoma, but that really doesn't happen as much with PD-1 inhibition or pembrolizumab. Usually we're thinking about things like a lichenoid eruption. So if we move further into feeling like we're comfortable with that diagnosis, then it becomes, how do we treat a lichenoid eruption? And the treatments could be like, there's a lot of different treatments that we could use. So the first thing I would think about, obviously topical steroids is something that we use for a lot of different things in dermatology. For this in particular, they are eroded, they're really thick, certainly reasonable to think about topical steroids, but I would do it under occlusion. So I'd like cake on a bunch of topical steroids, wrap the legs, do something called an una boot, where basically like you boot the leg up with this dressing, and so the patient can't even touch it and remove it, it just stays there all week. That's one thing you could do. You could inject steroid into these spots. Intralesional Kenalog might be helpful. It might even help you test an area as well. That's kind of a quick and dirty way to test if you're worried about something inflammatory, see if it gets better with an injection of steroid. And then often those aren't enough to actually treat lichenoid eruptions from checkpoint inhibition. And so then you start thinking about oral medications you can use. So a very common one to use is prednisone, because prednisone works quickly for a lot of these patients, and most oncologists reach for prednisone. The problem is that if you use prednisone, you're blunting the effect of your checkpoint inhibitor that's using the immune system to fight cancer. And so my entire shtick is to try to not use prednisone when I see my patients. So I reach for other things that sometimes can be helpful with lichenoid eruption. So often I'm reaching for something called acitretin, which is a vitamin A derivative. So it's like the adult version of Accutane. I shouldn't say that. Adults take Accutane too, but like it's similar to Accutane. It's easier to prescribe, and it's like a daily medication you can give. You can think about using things like methotrexate that is slightly immunomodulatory, so a little bit less desirable, but still not directly inhibitory towards the T lymphocytes that are fighting cancer. If it's really bad, I start thinking about stuff that's like a biologic. So sometimes for really bad lichenoid eruptions in the hospital, I'll actually reach for tocilizumab if the patient's IL-6 is elevated. So in my mind, those are the things that are swirling about in terms of things I would reach for to treat this.
Awesome. Okay, so the official read, very similar to what was discussed. This specimen exhibited compact orthokeratosis, which is basically just thickening of the stratum corneum. Scale crust, there was epidermal hyperplasia with hypergranulosis, which is something that can often be seen in lichen planus and lichen planus related eruptions. There's occasional junctional necrotic keratinocytes, which are highlighted. Can you guys see my cursor? Which are highlighted right along here, which is also typical of lichenoid reactions and interface dermatitis, like Stephen mentioned. And a patchy lichenoid lymphoplasmacytic infiltrate with eosinophils. Usually there are not eosinophils in, there's not a whole lot of eosinophils in here, but usually there aren't eosinophils with classic lichen planus, but you can occasionally see more of them in drug-induced versions. And then there was just background chronic venous insufficiency. And then one thing that wasn't in the report, but I just want to connect for people. So right here, you can see that the epidermis is actually separating from the dermis, and there's some hemorrhage. And that's probably a early manifestation of what eventually is seen as ulceration on the legs. So that's the skin starting to separate. So that is the last aliquot of information I have. We do have a follow-up after treatment. The story ends happily. But Stephen, I don't know if you want to put a nickel down on one diagnosis or another.
So I guess I would put down my nickel on ICI-induced lichenoid eruption, or what we will very soon be terming ICI lichen planus. And yeah, I think I would put my money there.
And you nailed it. So this was, in fact, ICI-induced hypertrophic lichen planus is what we call this one under the microscope. And it was interesting because, Stephen kind of called this from half court way at the beginning, where it can induce this hyperplasia of the epidermis, which mimics squamous cell carcinoma. And hypertrophic lichen planus is a classic mimicker of squamous cell carcinoma as well. So if you're not familiar with this, this can be treated in a more aggressive way than it needs to be treated, with surgery and things like that. And these often respond well to topical or oral treatment. And so just as for the reasons that Stephen mentioned, he was started on acitretin, and basically the lesions healed up completely, and all that was left over was post-inflammatory pigment change.
What a great outcome. That's great.
Yeah, so I don't know if we want to do learning points at this time, but when I was sending the case material to Madalena, Stephen, actually, I sent her a paper that you're an author on. So
Saw that.
That's why I figured you would have no problem.
Well, you're way too kind to pick a topic that's near and dear to my heart.
And Eamon, I just, what a phenomenal case. And thank you so much for preparing all these images and the pathology. It just really made for phenomenal learning. And Stephen, would love to hear your reflections on the case. And also maybe if you could choose 3 learning points you want to highlight.
Yeah, I think that what I would say about in general, in terms of thinking about this, is that this is where I think dermatology really plays a critical role, right, in treating our oncology patients. Because without a dermatologist involved in this case, or in this case, Eamon, like this patient would probably continue to be treated as skin cancer, and these spots would continue to get worse, and the 5FU would probably make these ulcerate even more and prevent the patient the ability to continue on his potentially life-extending therapy. So I think it's great in that he's got a great dermatologist treating him right now. And then the other thing I would highlight is that this whole area of dermatology of these checkpoint-induced toxicities is growing rapidly. So in the last 10 years or 12 years since these were first approved, what I'd highlight is that at least at Mass General, the number of administrations of checkpoint inhibitor has gone up exponentially. The only time it dropped was 2020 and because of COVID. But otherwise, like we have more indications all the time, including for adjuvant therapy and neoadjuvant therapy now. I will say that checkpoint inhibitors are not the perfect fit for everyone. We actually, like, sometimes the really sad cases are the patients who get checkpoint inhibitor early for non-metastatic disease and then do terribly from their immune-related adverse events. And so, like, you really need a subspecialized team of specialists to take care of all the IREEs. But I think the biggest thing is this sense of relief that I got the answer correct, and that Eamon was nice enough to pick something that I actually knew something about. So from teaching points, I think what I would tell you is that checkpoint checkpoint-induced immune-related adverse events of the skin are the most common and earliest to manifest. I think the other thing I would highlight here is that the actual morphology that the eruption takes is actually impacts the type of treatment that you pick. That's why it's really important to be specific about what you're seeing on the skin. And then I think for all of you who may not become dermatologists in the future, but maybe perhaps an oncologist or something like that, refer to dermatology early and often, especially for these types of cases, because I think we can make an impact. The other thing I'll highlight is that we actually just worked on a really large Delphi consensus project to actually name all of these and make an official, like, diagnostic criteria for all these different morphologies. That paper, I'm finishing up the revisions and I'm resubmitting it tomorrow to the Journal of Immunotherapy and Cancer. So hopefully very soon we'll actually be able to make some specific diagnoses, as opposed to what we were doing up until now, which is calling everything maculopapular. And I would just highlight, this entire time, neither dermatologist used the word maculopapular when describing the rash. So I'd encourage all of you not to do that too.
We'll not be using the word maculopapular. I had one follow-up. I have so many questions, but I will only ask one. I'm curious, we talked about how immune checkpoint inhibitor associated or induced lichen planus, a mimic of that can be squamous cell carcinoma. And how would you say, are there any ways early on, kind of what clues could be helpful to try to tease those two apart?
Yeah, I'll start and then I'll let Eamon chime in too, because you certainly treat these patients as well. I think from my perspective, I think here is one of those places where history is really helpful, right? If a patient's on a checkpoint inhibitor, it's awfully unusual to get an eruptive squamous cell carcinoma process. We do see eruptive keratoacanthomas with other types of cancer therapy, like BRAF inhibition is the classic one that we think about. But when we're talking checkpoint, that shouldn't be the case. And then in terms of the actual clinical lesion and the actual histologic features, I think this is where a lot of it has to do with, just like you saw, right? A lot of it has to do with history. This patient's biopsy was read as most likely atypical keratinocytic in the cancer side of things. And I was stubborn enough to say, sure, maybe, but maybe it's not. And we really need to think twice about that. And so I think having a high index of suspicion and knowing when you can pump the brakes a little bit and not cut everything out and maybe treat things stepwise to see how things go would be really important. Eamon, I don't know what you would add to that though.
I think that's awesome. And I think that you're really emphasizing the most important point, which is, like, given the context, what's the base rate that these are an eruptive malignancy. And sometimes that is your brain wants to reach for these unlikely things and you have trouble anchoring yourself in that, but I think that that's really important. For this guy, little clues along the way, I think, were that, as Stephen mentioned with the stomatitis, he sort of had this simmering picture of a lichenoid tissue reaction that started with oral symptoms. And then, can I share my screen real quick again? Looking at his initial picture, his shins very much looked like KAs, but a lot of these lesions on his dorsal hand, they have this like red, maybe pinkish purplish ring around the outside aspect of them, which sometimes, but not always, but sometimes can hint at a lichenoid or interface tissue reaction. And then if we look at the biopsy, you can see this kind of lichenoid inflammation in normal keratoacanthomas. But in retrospect, looking in the rear view mirror, you're like, aha, this was there all along. So that's sort of, hindsight is often 20/20, but when we look back, there's a couple little breadcrumbs sprinkled leading to the diagnosis.
Thank you. And Eamonn, would love to hear more about how it was taking care of this patient, and also if there were any key teaching points you wanted to highlight from caring for this patient.
As far as teaching points, I don't have anything to add. Stephen is literally the expert on this subject. Taking care of him was fun. He was like a super nice guy. His wife is super friendly. And I was just happy that the treatment worked so well for him. And I just want to say, Stephen, it was awesome to see you before getting any history, call out all the important aspects of this case, which, common lichenoid tissue reaction, the fact that it can induce squamous proliferations, it can induce, or like hypertrophic lichen planus, which can mimic squamous cell carcinoma. And then you like very beautifully went over the reasoning that goes into choosing a therapy for these patients. So I thought that was awesome.
Amazing discussion. Well, I truly, this has been such a educational hour. Eamonn, thank you so much for really expertly preparing and presenting this case. And Stephen, really phenomenal teaching and discussion. So thank you so much to you both. And Jimena, thank you for scribing, and Tansu for recording the teaching points below. And we will end the session there, but thank you again to everyone, and we'll see you again soon.
Great. Thanks for having me. Bye, everyone.
Bye, everyone.